So hello and welcome to this ARMA webinar on what a first contact practitioner can do for you. My name is Sue Brown and I am the CEO of the Arthritis and Musculoskeletal Alliance, ARMA. We're an umbrella body that brings together patient and professional groups to work for improvements in health services for people with musculoskeletal conditions. Just before we get started, we're just going to find out who we've got on the line today so that we know what our audience is. So I'm going to launch a poll, and if you could just answer those two questions just quickly, and then I will share the results. So the reason for today's webinar, the NHS Long Term Plan is aiming to see every patient with a musculoskeletal condition have access to a first contact practitioner by 2023-24. And ARMA's been a supporter of the First Contact Practitioner programme for musculoskeletal for many years, so we're really delighted to be supporting the current rollout. NHS England and the Chartered Society of Physiotherapists have been providing a lot of practical support to people rolling this out on the ground. And this webinar aims to give an overview of FCP and how it works to people who haven't yet been involved, or to those who aren't directly involved but know that FCP might change the way in which musculoskeletal services are delivered in their area. So after an introduction to the programme from the CSP, we're going to hear the perspectives of a GP and a commissioner who have established FCP services in their area, and we'll be able to talk about the benefits from their point of view. But just before we go on to introduce our first speaker, I'm just going to share the results of the polling, just so that we have an idea of who is on the line. So the largest group of people on the line is commissioners, followed by other. Other is usually quite a large group in these. But we've also got service managers, practitioners, people leading service transformation, and some academics. And the majority of our participants today work in CCGs, but we've also got a whole spectrum: GP practices, community services, hospital services, some from private practice, and again, other is quite a large group. So that's who we have on the line today. So I'm just going to stop sharing that, and I'm going to introduce our first speaker, who is Sarah Withers, who is Head of FCP Implementation at the Chartered Society of Physiotherapy, and can give us an overview of what FCP is all about. Sarah, over to you.
Thank you. Thank you for your introduction, Sue, and it's good to be here. I'm just going to do an introduction about FCP and the benefits that we can expect with this approach before Robin and Rebecca speak. It's one of the interventions that can really have a positive impact on MSK care. First contact practitioners incorporate a lot of the approaches that we know are beneficial for improving care: personalised approaches, using shared decision making, promoting self-management, and as well as really using the evidence-based pathways that there are in place already to make sure that patients get the best care for them, crucially right at the first time that they seek support. First contact practitioners are autonomous, who independently assess and diagnose and use wider investigations and referrals onto other services to support people, as well as using brief interventions themselves. They often use independent prescribing and administration of medicines to enhance their core skills, as well as referring directly to others. Many of these skills are already established in MSK services in community and hospital-based settings. And so what we're doing is really adopting this first contact practitioner role right at the very beginning of the pathway, in order to bring new expertise and new capacity at that point. Just trying to move my slides on, so please bear with me. There we go. And so these are the things that are included in an FCP consultation. At the moment, around 1 in 5 of the population in England have access to an MSK FCP, although that's not necessarily a consistent figure with the same coverage in every area. Usually the FCP will work in a GP practice, occasionally in a hub, but they usually use all the same systems that the staff in the GP practice use. So the reception team can navigate and book the patients in directly to an FCP clinic. And the FCP will be using the GP clinical record and the same practice-based systems as all the other staff. So all the clinical information is there, both for their consultation, but also feeding back into that record. At the consultation's core is safety and effectiveness, which is supported by that ability to manage all sorts of patients with MSK presentations or potential MSK presentations, handling the uncertainty and risk that comes with an undifferentiated caseload. An FCP will take the same approach in a consultation as a GP will. So first line assessment, diagnosis, and first line treatment or onward referral. An FCP doesn't offer a course of treatment in themselves within the practice, but early access to MSK skills and expertise. So measures of success for this approach really focus on that safe and effective care for patients, the impact on the healthcare system, and the experience for those involved. An NHS England Evaluation of FCP services is taking place, as many of you will know, over 2018-2019, and this will measure the impact of the model in England at the moment. 41 out of 42 SCPs have an FCP service taking part in this, and they're testing the hypothesis that FCPs improve the experience of patients with MSK conditions, reduce the pressure of pressure on GP workloads, and streamline pathways of care, improving outcomes for patients. And they may do this by reducing the number of unnecessary MSK referrals into secondary and community care services, and reducing the workload of GPs, whilst they're providing assessment and self-management advice and a good experience for patients and a good patient outcome. And so to answer these questions, services in STPs have been collecting information on planning and structure and governance of services, as well as the consultation data. And there's also a concurrent arm of evaluation going on, being run by Keele and Nottingham universities. And that project is looking at patient experience and outcome data in terms, and also looking at the experience of primary care teams, GPs and FCPs in delivering this model. In the next year, STPs are required to select at least 2 further sites covering approximately 50,000 population to add to that 2018-19 cohort and establish those FCP services in those sites to build on the work that's already been done. So we know that service evaluation so far has shown consistent trends that FCPs speed up access to MSK expertise and appropriate interventions. They increase the number of people who have specific self-management advice at the beginning of the pathway, and they have conversations about work in significant numbers. There are high satisfaction rates from GPs and FCPs, and perhaps less expected to some is the equally high satisfaction rate amongst the public. Contrary to feeling fobbed off or downgraded, people who see an FCP report high levels of confidence. We are also seeing that FCPs are saving time and resources across the pathway, reducing pressure on GPs. Usually in the evaluations so far, 1 to 2% of patients who have seen an FCP need to go on to see a GP. and there is reduced testing, onward referral, and reduced practice prescribing. There are key characteristics needed to be in place really to deliver these benefits, and they're outlined in the high impact intervention guidance published in May 2019 by NHSE. FCP roles are part of MSK transformation in improving care and supporting capacity, and the importance of the level of skill, the importance of the engagement of the whole primary care and MSK pathway team is highlighted in that. The NHS Evaluation report from the evaluation that's going on at the moment with the governance and consultation and early qualitative experience data is expected this autumn, and the further experience data and outcome data will be published by Keele and Nottingham in 2020. So the expectation is that FCPs embedded in primary care and working across pathways will bring benefits. They'll bring benefits for patients to early access to specialist expertise and action, speeding up accurate diagnosis and appropriate support. For GPs, an FCP frees up a significant number of appointments for patients with multiple problems, as well as the opportunity to upskill potentially in MSK for some. And for secondary care services, referrals made at the right time with the right information translate into more active care. For the healthcare system, costs are reduced associated with unnecessary testing, prescribing and referrals. But of course, what's important to deliver these improvements is how to effectively translate and implement a change into practice, which is often less straightforward than it seems and has its challenges. So I'm now going to pass on to Robin, who's going to speak about his experience in practice.
That's great. Thank you very much, Sarah. And that's a really good overview of the programme and what it's aiming to do. So we're now going to hear from Dr. Robin Harlow from the Willow Group of GP practices about what actually happens in practice when you do this. As I said at the start, we will come to questions at the end of the 3 presentations, and it would be great if people could pop those questions into the Q&A box so that we can keep track of those. Robin.
Okay, hello everyone. My name's, as said, Robin Harlow, and I'm a GP at the Willow Group. We're a practice in Gosport, and I came to the Willow Group about 3 years ago to work with them as they all came together. They were originally for individual partnerships, working independently, but due to the adverse conditions and difficulty in recruiting GPs in the local area and providing an ongoing sustainable service, the partnerships came together and then also partnered with Southern Health, which is our community provider locally and mental health provider. So we are a partnership with Southern Health, and I also work as a clinical director within the trust. We were involved with the National Vanguards on the MCPs, and as part of that, we looked at how we could redevelop our services. As I said, there's been significant pressures on the fact that we have few GPs and it's been difficult to recruit there. So it's all about how do we look at other alternatives and actually get patients to be seen by the right person at the right time. And as well as having a first contact physiotherapist, which is a more recent addition to the team, we have a wider team looking at all different aspects of care. So we work closely with our nurses on one site, delivering long-term care for diabetes, COPD and asthma. We have standard GP care across the whole site, delivering whole population care. And we have a same-day access service that provides the emergency care for all our practices together. And we're about 36,500 patients. And originally, when I first joined, the same-day access service did pilot a physiotherapist at that point, following a successful pre-pilot on one of the original sites where they'd shown a 25% reduction in physiotherapy referrals from their service in secondary care as a result. The pilot ended within the same-day access service, and about 6 months ago, I spoke to our MSK colleagues within the trust to see how we could work together to develop a service that was First Contact Physio. And it's been very successful since, really. So I had ambitions far way ahead of where we are. So I hope that we would probably have about 3 or 4 physiotherapists working full time based on some figures that came down from the National Centre about how many GP appointments could be saved by their role. But obviously, due to other restrictions of the service that we currently provide and funding and things, that we started to pilot with just 1 day a week. So we have 2 of our MSK practitioners working 1 session each. They see 10 patients per session, and in total there's 2 sessions, so that's 20 patients a week, and they provide 20-minute appointments. I think one of the big advantages that we do have, and hopefully this is a model that we're going to move forward as we go into the PCNs, well, from PCNs where we are at the moment, PCNs next year involving funding for FCPs, that we can adopt an integrated approach. So we've got the physio, the advantage of them working within primary care, but also then seeing patients in secondary care, and I'll talk a little bit about that later on. It's a joint risk share, so as I mentioned, we hope that there would be evidence that there was an impact on secondary care referrals. So the Trust agreed to fund from the MSK service 1 session, and then the Willow Group funds the other session. To deliver the service, we've got a memorandum of understanding. So as I mentioned, provision is 2 4-hour sessions. Practitioner works autonomously, so they offer advice, guidance and referral into other services. And again, I've got some data to show where those patients are going. Care navigators, so we have a telephone hub, all patients ring in and ask for obviously appointments and our triages as to which service would be best. And we have there's an NHS sheet that shows the criteria that's recommended for FCP, and essentially it's most patients that have got either neck, shoulder, knee, back pain, and they're offered an appointment with the physios. They don't at the moment have the ability to prescribe or refer into x-rays or blood tests, but again, I'll mention that later. The incidents and complaints are managed within our trust processes. They record within our GP records, so we use EMIS where we are. And support is provided both from the practitioners within the Willow Group, so a duty GP that's working with them on that day, but they also continue to have regular supervision from and clinical mentoring from our lead within the trust. So that happens every 4 to 6 weeks. They work together and have regular email contact between themselves as well to provide that sort of ongoing relationship and support between the 2 FCPs. As I mentioned, they have had 6 weeks of training prior to, again, by our lead within the trust, who gave supervised clinics. And they also had some training within house on our own systems, so on how to use EMIS. So the trust use Rio for their community services, but we use EMIS for our primary care service. I mentioned to you about inclusion criteria, exclusion criteria for patients who are unwell. We obviously provide a clinic, finance I've mentioned to you, and human resources. So we manage the operational side of things specifically for the FCP role. As I mentioned to you, we have wide-ranging criteria for referral into the team, which in itself, because the service is so small, for 36,500 patients, we currently have a wait as long as it is to see a GP appointment at the moment, but at least we are missing out that GP step. So they can go for neck pain, shoulder pain, elbow, hand, wrist, hip, knees, foot and ankle. So I've spoken to both the FCPs and our GPs, so they actually are really enjoying their role. And I think it's really important to give actually live feedback as to how they're feeling about the experience, as well as from a sort of business point of view, and how they see that going forward. So the fact that it's added to their working role, and they're able to develop portfolio careers. So they're not doing all FCP. They may have also a management role. As I said, they've also got a role with MSK, so it's adding to their portfolios, which again brings more interest and hopefully will also add to sort of recruitment and retention within the service. They reflected on their ability to refer, so they can see a patient, they can directly refer into the specialist MSK service. It improves patient engagement. I thought that was a really important point to capture. So actually, I suspect as GPs have been having a discussion again this morning with a couple of our FCPs and actually physios within the MSK service about GP knowledge and understanding about what we are actually referring into when we say to a patient, we recommend referring into physiotherapy, or the patient comes in asking for physiotherapy, and what their expectation is of that. And actually having the physio to be able to discuss that with them prior to then going off and having a course of treatment with physiotherapy has improved engagement. They felt that a 20-minute appointment was sufficient. There are some barriers, as I mentioned to you, so in particular looking at how investigations are organised. So we have a task system within EMIS, so the first contact physio may see a patient, they think that they need to have an x-ray done, we need to have some medication prescribed, or that it may be worthwhile having some blood tests done, then that task is sent to the duty GP or the patient's registered GP to then action. During the day, they do have an open door between them, so they can work with the duty GP and ask them to come and review anything that they're not concerned, that they've got concerns about, and actually equally vice versa. So if a GP is seeing someone, they can knock on their door and say, would you be able to come and give an opinion on this? Another really important element to capture, and this is a difficult one from looking at data, but actually understanding why GPs are doing referrals. So if you've got the FCP working out in primary care, they actually are understanding what GPs are seeing on a day-to-day basis and the volume of work that maybe we're seeing. And we're not referring every patient into physiotherapy, that we do try and gatekeep it. And that may have not been so acknowledged and recognised before. So I think there's that, again, that relationship building between primary and secondary care. Talked about email support that they provide each other. And although this isn't the main aim of the service, the GPs are, and again, this was mentioned this morning, but some of the GPs are referring into them for a second opinion or for physiotherapy, which, as we know, is not their main role. There was a comment that if, the fact that they're only there once a week at the moment, so if they are arranging for investigations or they've asked the GP to undertake an action, then that may get delayed by another week because they're not back on site until then. GP feedback mentioned to you, so they feel it works really well if the doors are opening and everyone is questioning all the time. Sharing knowledge and skills that neither have, and they're both sharing and learning. And that's been of great value for all of those involved. The GP is able to provide support for less common presentations. And actually I thought was an interesting point to raise is actually their exposure is higher to more diagnostic uncertainty in that broader picture because they haven't been seen and gatekeeped or triaged by a GP originally. So again, that's where having the open door and the duty GP on site is helpful. So I've pulled out some data. So when they're working through and seeing the patients, they complete a template on EMIS, which pulls out some of this data. And I think the plan is actually there'll be some national standards to look at this, but this is what we've been doing in-house. And as you can see, the majority are the big joints. So shoulder pain, knee pain, hip pain, lower back pain, ranging then down to some very handful of specific conditions. But say the majority of the big ones that you would expect, not osteoarthritis. And then the outcomes. So out of those 180 patients or so that have been seen in the last 3 months, 65% have been given advice. 65 patients. So 35 have had exercise on prescription. Now I just need to clarify that with the team as to whether they mean that that's the exercise that they're providing them. So they're giving them some exercise leaflets to go away, explanation of what to do, or whether we also have a service locally where we can refer into the gym for exercise. As I mentioned to you, they can refer directly into their own MSK service, and the advantage of them having already seen them and assessed prior to that. And I think highlighting about the number that go back to the GP, so 6 out of 180, so a very small number then have been recommended to go back into general practice. We've not had any concerns that have been raised through the last 3 months. We've not had any significant incidents that have been raised over the last 3 months. So it appears so far to have been a very safe service and a well-received service by patients. I think it's really important that they're told by the care navigators or the receptionists about who they are going to see. So there was a comment this week that one of the patients had expected to see a GP. But but the care navigators are advised, to explain what they are referring patients into. Our next steps, so we were piloting the service up until the end of August, so we were doing a 3-month pilot. We're expanding the service as it is until or extending, should I say, rather than expanding, so we're extending the service up until the end of March, which of course is then when the PCNs will be receiving funding to develop FCPs. And we, as part of this joint approach, are hoping that we can develop a business case to look at how we model up an integrated service, and that we can offer that to work with the PCNs to develop that in there's a trust. How do we provide support, education, training? How do we provide that ongoing professional relationship and governance structure that's needed behind the service, rather than having the risk, which is one of my concerns, is about PCNs having isolated practitioners. Upskilling, so developing injections, being able to inject joints, having their IRMA training, and working with our acute trust to improve them to be able to order x-rays. One of the FCPs specifically talked about wanting to do some training in pathology, so is there a way that we can put up a structure around ordering blood tests, what would be appropriate, when would they be appropriate, and then about understanding and interpreting those blood tests. Thank you.
Thank you very much, Robin. And we've got a few questions coming in, which we will come to when Rebecca has had a chance to do her presentation. So Becky Keating is the Planned Care Commissioning Manager for Somerset Clinical Commissioning Group. And Rebecca has a bit of feedback on her line that we can't get rid of because we can't work out what's causing it. But we hope that you will be able to hear what Rebecca has to say. Rebecca, there's quite a lot of it at the moment, but hopefully people will be able to hear you.
I can only apologise. I'm sorry. I hope you'll be able to still hear what I have to say. Thank you, Sue. So hello. Yes, absolutely. I'm Becky Keating. I work for Somerset CCG, which is in the southwest region of England. I was very fortunate to have been involved as part of the NHS England First Contact Practitioner National Evaluation that Sarah referred to, which was starting in 2018 into 19 and continuing on. This has meant that actually I've been involved with our local FCPs. At the time, we had several general practices that had commissioned directly with local acute providers for FCP physiotherapy in their surgeries. And this was because we were involved in the first wave of the FCP pilots, which started, I believe, in about 2015. And so this is we're part of the handbook that's available on the Community of Practice with that case study. As we had several FCP sites across the county, we agreed for them to contribute to the national evaluation with submitting a common data set which came into us at the CCG, and we uploaded on their behalf, and we continue to do that. We're really pleased with the progress to date and how our FCP development has been actually driven by our clinicians doing the roles and actually kind of building on what's already working here. We really hope our PCNs will consider this as a great opportunity to include in their teams going forward. As you will be aware, it's been referred to before, it's one of the workforce roles that has been recommended as part of the extended multidisciplinary team for PCNs. And I'll share today what we've been doing in Somerset and what an FCP can do for you. So, MSK health issues do account for about 1 in 5 of all GP appointments, and many could be seen first time by an FCP practitioner. Recognising that not all general practitioners have a specialist interest in MSK, the person would be referred forward to the originally to the MSK interface service. This takes the step out of that process. So the recommendation is actually that each PCN has one full-time equivalent at least, First Contact Practitioner, and there have been a range of pilots over the roles, and these are offered on a reimbursement basis, so that's in additionality to what exists already. By having an FCP in your practice, you increase the amount of skills held within it. An FCP is able to offer assessment, diagnostics, and treatment all in one session. This offers an improved patient experience, as they will be seen often in a more timely way and close to home as well. So as you can see, we do have advanced practitioners working within the primary care setting with an extensive expertise in the clinical assessment, diagnosis, and management of conditions. So as has been stated before, they're able to get their appointment directly from reception, but they're still able to access their GP if that's what their preference is. So in Somerset, we are progressing for physiotherapists to fulfil this role, but there are other professional disciplines that are also able to do so, as long as they're able to meet the same competency framework. So we have our case study. So this is from the handbook that I referred to previously, and it refers to our first wave of pilots, which started in one of our surgeries, the French Weir Health Centre, in 2015 in September, and was continued until they reviewed in December 2017, and also the Warwick House Medical Centre, which started in 2016 and through to December 2017. So their model is 8 20-minute appointments per session, and the French Weir Health Centre had a 0.5 whole-time equivalent, and Warwick House had 0.2 whole-time equivalents. So I think it's fair to say that even though we have a range of different sites across Somerset, we do not have any with the current requirement for one full-time equivalent across the PCN. So as you can see from the results, we have had a vast number of consultations. 40% of the contacts were seen by the FCP. But there were also some that were actually referred on from the GP as a kind of an extra step in the process, recognising that the value and skills that they could offer here. Across both of the GP practices, so half of patients were seen within 7 days, and this increased with the increased amount of FCPs available. So the results around how many patients were managed independently was, I believe, an impressive 75%, 75.6%, with 14.7 and 6.1 referred to physiotherapy and intermediate or secondary care services respectively. So there was a definite, it was felt that there was a relationship between the introduction of the First Contact Practitioner and this shift within the receiving services. As again referred to previously, there was excellent patient satisfaction. So I think, you know, kind of the First Contact Practitioner does absolutely enhance our offer to our local people. So slide 5 shows the First Contact Practitioners do offer a range of skills and have the ability to independently support many of the people that present with a range of MSK conditions. They're also trained to identify some of the red flag symptoms that Robin referred to previously, and so we'll escalate if clinically indicated. So thinking around specifically what's happening in Somerset around the FCPs is we had a system-wide workshop earlier in 2019 to actually look at the varying models of actually how first contact practitioners might work in a wider system way. We wanted to promote to have a consistent approach to ensure that there is a reasonable amount of equity for our residents. So we came up with 3 different options, but actually has a preferred one, which again relates to what Robin referred to earlier, the combination of the FCP clinicians actually being seconded into the sessions in the GP practices, and actually having that kind of foot in 2 camps approach, where they benefit from both the support and the governance framework across the professional group. Also is absolutely improving the diversity of their skills and experience by actually getting that primary care experience too. So I think it definitely offers quite a compelling improvement on kind of career pathways and those options, as well as actually having a really resilient model where we have a pool of very highly experienced and specialist practitioners available with that whole pathway knowledge, and may entirely see a patient in several settings, which really helps with that continuity. So our FCP pilots demonstrated that quicker recovery for patients with 50 to 70% discharged after only 1 consultation, the integration of shared decision making into a patient's pathway really early on, the improved use of diagnostic capacity with cost reductions in plain X-rays and MRI scans ordered from general practice, appropriate referrals into secondary care. We're very lucky by having such a well-established MSK interface service, but again, this this enhances our local model. There's also that 90 to 99% satisfaction rate in the pilots as well, referring back to the excellent experience. So referring to the evidence base that the NHS England have compiled as part of the evaluation, the recommendation is that there is a likely return on investment for between 0.81 and 2.37 pounds return for every £1 spent on implementing FCP services. And so that was reference to Davies in 2017, with some studies suggesting a higher return. So recognising that every system is different and has different population needs, but definitely kind of FCP is good value for money and a good investment. Again, referring to the clinical case for change, the benefits around reducing the GP workload, recognising that both GP availability and the demands there are kind of higher than ever, and increasing, that timely access and building self-care into the expertise, so that actually people are able to manage their own conditions more effectively. So recognising also the impact that MSK presentations have on the kind of the consumption of local services, the impact on people being able to access their work, people's mental health, and also within the rest of the system. So I referred earlier to some of the workshops we held earlier. So we wanted to talk about a workable employment model, and at the system workshop, we have made a recommendation But however, since the first workshop, the primary care networks kind of came into play, and so that changed actually the way that, you know, kind of things were previously commissioned. And so now it's the primary care networks that are actually choosing whether they wish to have a first contact practitioner within their services. So even though it's one of the recommended work roles, it isn't mandated. So I think it's important to recognise that, which is why, you know, it's really important that we're here today to share actually all the benefits that are there. So also on this slide, there's a really supportive quote from one of our GPs at the French Weir site. So having the backing of our GPs is absolutely essential, and we look to them to actually speak to their peers as we look to try and roll this out and spread across the county. So this is how we kind of put our model together, and so you can see by referring to it, so it aligns with our strategic aims of delivering specialised services close to home. The FCPs are able to signpost to community assets, empowering people to self-manage through educating them about the lifestyle changes that they can do, that they can make to stay well. FCP should absolutely improve outcomes and the experience of people with MSK conditions and help reduce unnecessary demand on GPs. So I've already referred to the workforce resilience, the quality, you know, by having a Somerset model, we offer a consistency in both process and workforce across the county. I have already referred to actually, you know, we've got a really strong MSK governance framework and an excellent pool of highly skilled MSK clinicians. There's an opportunity for that shared learning across the teams. We have several acute providers and community providers in Somerset. So, you know, it's a really good collaboration where actually everyone gets to win. So we, you know, would like to see the FCP as being absolutely part of the primary care network multidisciplinary team. The FCPs do absolutely document in our EMIS systems as well directly, so everyone's got access to the live information and referring to their skills. So just a brief nod to, you know, kind of some of the concerns around some of these extra roles is that some are seen to attract DAT. So this is a slide that my colleague has prepared. However, I do need to say that we would always recommend that you seek independent financial advice when you have actually decided on the model that you would like in your area. But I think, you know, what is key that actually the MSK First Contact Practitioner would not, I believe, attract a VAT levy as it is considered a medical care service, which I think is good. You know, we don't want to have those extra barriers in the way to being able to implement this. Okay. I will finish off there. Thank you.
Brilliant, thank you very much, and thank you to all of our speakers. There's been various questions and comments coming in the comments box, and there's one in the Q&A box. Now's your chance to ask people on the webinar if you have any questions about how it all works, what it's like in practice, any of the questions that you have. I have to say, one of the issues I didn't expect to be dealing with when I got involved in supporting the FCP programme was VAT. So some of the things that come up can be not quite what you expected. So we've also had some questions about what we will be sharing. I need to check with the presenters if they're happy for their slides to be shared, but we can then put them on the ALMA website and share a link in the post-webinar email. We'll also share a link to the competency framework, because we've had one or two questions about who can and can't be a first contact practitioner. And the answer is you need to be able to meet the requirements of the competency framework in order to do the role. It's not related to specific training or qualification or profession. It's about having the right competencies. So yes, do ask any other questions that people might want to ask. Something came up in the comment box about Care Act assessments, and do FCPs do Care Act assessments? I know what I would guess, but does anybody have a more concrete answer to that?
I've asked, while we've been online, I've asked them and they say no, they don't.
Yeah. And my guess would be that so the Care Act assessment service will be commissioned by the local authority. So I would hope that FCPs are able to advise people on their right to a Care Act assessment if that seems appropriate, but they probably would not be the service that was actually commissioned to deliver that. We've got a lovely, broad, open-ended question here. Thank you, Charlie, for this one. Have you any advice on the implementation of a new FCP service? So what would be your advice to someone who's starting this up new? Anyone want to give that one a go?
So it has worked very well, but I think it's worked well because we've had that integration within the relationship with the MSK service, and built the model up. We've gone in at a low level to start with to test the model, make sure that the processes are working and that they're working well. So I think it is having those conversations with your other providers to see whether there is some joint work that can be done, would be from my personal history of it. And continuing to explore the options, continue to ensure that your care navigators are trained and understand which patients are appropriate to be going into the First Contact Practitioners. Patient education, I put an answer on the slide, but I think patient education and engagement is really important so that they understand what they're being offered and provided, and that they're happy with that, and that patients are now I'm really starting to see that patients are much happier with seeing alternatives to general practice and see the advantage of GP, should I say, and see the advantage of that as well. I don't know what other people's thoughts are, but they're just a few.
Yeah, could I add to that? I agree with Robin. I think it's really important that everybody is involved in the development, and that's where we've seen successful implementation. It's really, I would say, crucial that everybody understands what this role is, that this is access to MSK expertise for people coming to the GP practice who need that. It's not about self-referral to physiotherapy. It's not about early access to treatment. It's about that assessment, diagnosis, support for that first line intervention. And I have to say that in absolutely most cases, it has been possible to get the investigation and referral pathways up and running very quickly. And so that helps people understand that the role isn't self-referral to physiotherapy, or it's something else. And for the whole of the clinical team and the non-clinical team in primary care, that understanding of the role seems to be crucial to getting the right people to the right place.
Becca, have you got any tips for people starting out?
I think it's just worth saying that actually there are so many resources available from the actual pilots that have been kind of promoted in the 2018-19 wave, that actually kind of there's plenty of help there. There's plenty of other areas that have tried this before, that kind of that you can connect with, but absolutely echoing everything that Sarah and Robin have said too.
Great. And I think one of the things I might add is that I think FCP is not a replacement for having a good MSK pathway. It's part of a good MSK pathway, and it will work best where the rest of the pathway is also working. Great. So I hope that helps. We had another question in the comment box, which was around paediatrics. Has anybody got any comments or thoughts on paediatrics and FCP?
I guess I could just say that at the moment I'm not aware of any specific paediatric services, and many FCP services will see patients who are 16 and up, although I think some of them in local areas are developing for slightly younger patients. So it would be really interesting if you'd like to get in touch with us at the FCP email box for us to have a conversation and hear about the work that you're doing there.
Great, thanks. And then there's a question about this is always one of the things people want to know. What's the evidence around the reduction of referrals through to other services? And could a reduction in use of other services help to fund the FCP services? Anyone want to pick that one up?
So I just typed a very brief answer, but as I said in my presentation, we as a GP practice fund one session of the FCP, and the MSK service funds the second session. So we've taken a joint approach and risk share, but to recognise the fact that they expected a reduction on referrals, which we evidenced previously when we did a pilot. And as I understand, there is national evidence that suggests what level of reduction and impact there is.
I think that will become clearer. That will become clearer following the evaluation publication. And I think a lot of it depends on what services you've already had in place in your area. So for example, places where there have been well-established community interface services and so on have seen a reduction in onward referral to secondary care specialties, but not as greatly as you would expect as those who didn't have anything outside secondary care beforehand. But there have been benefits shown across the whole pathway in primary care in terms of reduced prescribing and testing costs, in MSK for reduced referrals to physiotherapy and reduced secondary care. And I guess it's for the onward discussion about the relative costs and savings there. On the whole, I would say referrals to physiotherapy are much less expensive than referrals to secondary care specialties. And so it may be that there are more savings to be released in other parts of the system.
Great. Becky, did you have anything to add to that?
Yeah, I think our local position is that we do have a very well established MSK interface service that we spoke about earlier. But I think, we would absolutely see that, we would anticipate that there would be probably less referrals going through. However, with our local demographics, we expect our demand to grow. And so actually, instead of, taking out that, investment in those services, we see FCP as an opportunity to help us manage growth as well.
Brilliant. Thank you very much. So we've just about come towards the end of our time, and I think we've also covered most of the questions that have come in. So thank you all for joining the webinar, and I hope that you found it useful. The recording will be available shortly, and you will all be sent a link to the recording so that you can share that if you want to.